prioritize your patients. Number one.
Yes,
If
yes, yes. That is the
your
point.
attitude is good, your patient will tell you everything on its own. Okay. My consultation
Yes.
lasts for 40 minutes to 1 hour. In 90% of times, my patients keep talking, they cry. मेरे टेबल पे रोते हैं, खाते हैं, हंसते हैं, कॉफी पीते हैं, खाना खाते हैं मेरे टेबल पे और जाते हैं. I don't see a lot of patients, Ankit, in my clinic. But whoever I see,
If you are able to make a connect with your patient, if you
right,
are able to make a connect with your patient tells you everything about him also, and after some times they discuss their family problems also, because
that is trouble
they
come. Right.
they build up a lot of faith in the doctor. So this
Yes.
is
No, I completely
you.
agree, sir.
Yeah, yeah,
I just wanted
yeah,
to reframe it. I'm not
yeah,
talking about hypnotization, but so the case scenario is that a lot of kids are watching their Cartoon Network, and they came
Right.
yeah,
across channels and a lot of junk food stuff. So when they
Okay.
visit Dr. Arthur, so Dr. Arthur tried to use a therapy to unlearn those, junk food and let them eat a lot of healthy food. That is what they are
yeah.
practicing in America.
That
Ankit,
yeah,
not
that
required.
may be good policy.
Again, not required. I'll tell you why. If you have a good connect with your patient, your doctor Saggu ji will agree to me. You say a word and the patient will follow it as a gold standard. Okay.
Yeah, yeah,
Say a word and patient will take it blankly. But that connect you need to have with your patients. Okay.
yeah.
So it does work. You don't need hypnotism. You need to
No,
have
I
good
know.
faith.
See, I'm not in.
And
I'm the
Yeah,
yeah,
viewer.
no,
and
what I'm trying to tell you is this is a live show. This is a live
and
show.
He was sharing a couple of
And many
examples
people are listening to
with
us,
kids.
Ankit.
He was sharing a
Many
couple of
people are
examples with
listening to us,
kids. He
right?
was sharing with people who do smoke basically. So how
Yeah.
you can let people don't smoke. So these
Yeah.
kind of practices he do with those patients basically.
Yeah, Ankit, let me tell you honestly, I'm not against him practicing. He can practice whatever he wants in UK. We're just sharing with us. But for the benefit of the viewers, I want to tell this thing. All such methods are not required, basically, in
Okay.
today's world. There's so
Yeah.
much of information with us, and there's so much of good things we can do, right, sir? You'll agree to this.
yeah, yeah, yeah,
And
yeah,
some
yeah,
knowledge
yeah.
we can share
So
that,
each
अरे
and
hypnotization से तो
yeah,
छोड़ दो यार, ऐसे ही तो हो जाता है patient आपके साथ.
each and every field is very important. Whether you
Yeah.
are a neurosurgeon, you are a pediatric surgeon, you are a gastrosurgeon, you are a pulmonologist, you are a dermatologist. So if you deliver your more than 100%, if you are able to make a connect with your patient, I think you can serve people each and every field, and you have to be expert of that field. You
Right.
should know each and everything about that field.
Yes.
There is no need to jump to another field. I think you can serve the people very nicely in the same field.
I agree to sir that we can serve the people best in our field. Like
Yeah,
respiratory,
yeah,
मुझे
yeah.
नींद में भी अगर पेशेंट पूछेगा तो मुझे पता है मुझे क्या करना है. सर को
Yes,
सर के
yes, yes.
ब्रांच में कोई पूछे तो उनको पता है उनको क्या करना है. There are so many people
बिल्कुल,
like us, right?
yeah.
We need to just be positive. That's it in this situation.
And also, sir, I would like to know that post-COVID, if we talk about the future of healthcare, do you see technology or artificial intelligence will change the healthcare while dealing with the doctors, or maybe doctors are utilizing a lot of AI on their day-to-day work?
Okay, coming to AI question, Ankit, AI can only tell you what is fed in this algorithm.
Yeah.
Very specific. There are algorithms. There's a look for AI, thinking look for AI, which algorithm this values it assembles, and it comes out with an answer for you, right? If the person who's fed the loop has fed it well, then you have possibilities of getting good answer. If there's a mistake in any of the algorithmic things, or if for small amount of instance, let me tell you, because I'm also a technocrat geek. A cockroach comes in and it's puts urine on your exit on your computer system.
Yeah.
Your system goes for a toss, sir. And then you find all illogical gizmos coming out. Rather than trusting the artificial intelligence, see, artificial intelligence to be used when we are overworked,
Yeah.
when we don't have time, right? We want a quick remedy. But my personal feeling is, खुद के दिमाग पे भरोसा रखो. खुदा ने एक अच्छा दिमाग दिया आपको, और ऊपर वाले पे भरोसा रखो, सब सही हो जाएगा.
No, but sir, I completely agree. But I think that when you talk about large amount of data around the world, you need to have
Right.
some solution so that you can and
I agree with you on that front. A large amount of data need to be segregated and need to come to a conclusion. But
Yeah.
artificial intelligence still what thing? Now here's a question which I want to put to you, because I am also associated with the partly of project called Jarvis, which is an artificial intelligence project.
Okay.
If you induce a self-learning loop in this artificial intelligence. Man, we cannot control it. Self-learning loops. You're getting it.
See,
The machine tries to learn on
I
its
got
own, and
I
it
got your point.
gathers it on its own, right? So it's our responsibility as individuals to restrict for our existence on this planet. Maybe what I'm talking is far-fetched for some people, some viewers, but it is not far-fetched for many people in the branch which is
No, sir,
dealing with artificial intelligence.
I'll tell you, I am a technology entrepreneur, and
Yes,
I'm
sir.
doing course more than 10, 12 years. And when you
Yes,
talk
sir.
about artificial intelligence, there are different ways and fields to do it.
Yes,
My
yes.
concern right now is that everyone has a lot of data, including you,
Right.
including Dr. Saggu, including all these
Yes.
hospitals around the world. But are
Yes.
we utilizing the data in a manner so that we can treat our patients, or maybe we can treat our next patient? I'm not saying you are not doing it, but I think we can do it in a much better, appropriate manner.
Uh,
It will be easy for us to.
yeah, you can do
Yeah,
it in a.
I think we can increase the number of the publications using that data.
Yes,
So because
yes, yes.
earlier, suppose a lot of things were we have huge data, but that
Mm.
data we have not been managed systematically, and we have not make a lot of publications from that data. So
Yeah.
this time is teaching us to review the data, to review the
Yes,
other publication, and to use that data for the publication. So
right.
I think the post-COVID era, so we would like to have a lot of publications there. The research work will also go on, and we would be doing more teleclinics, and we would be doing more tele meetings. So the telemeetings and the teleclinics will going to save us a lot of time, and that time we can use for the research work and for the publication.
बट
So very, very well said.
सर एक सवाल है आपसे टेली मीटिंग टेली क्लिनिक अप्रिशिएटेड और जो एक दूसरे को फेस टू फेस मिलने का मजा है वो कुछ और है सर
Bilkul initial screening, for the initial screening, and maybe because 100% patient doesn't need you for the
yes
second
yeah.
visit,
Yes,
right?
yes, you are
So
absolutely right, absolutely
yeah,
right.
you can screen your 40 to 50% patients who needs a second visit, and that second
Hmm.
visit would be in-person visit. So
Yes,
initially you can have a screening. So yeah.
right.
And also, sir, and also with artificial intelligence or maybe with the data, we can also create a lot of programs and policies so that we can prevent the disease happening. We are not
Yes,
working on
yes.
the prevention as of now, and
Yes,
that is
So
what
we are not
so
living with
because
the
a lot of
so
data involved.
th-
I'll tell
yeah,
you,
this will
Dr. Saggu
this will
knows
help you to make a lot of protocols, to make a lot
protocols.
of guidelines. Yeah, that is true.
Because I
That is
think if
true.
we start working on the prevention, that is what we are doing right
Yes,
now for on the COVID
yes,
situation.
Yeah,
If we try to
yes.
yeah,
prevent ourselves, I think we will be in a good manner, and I think it will be helpful for doctors as well to treat the
Yes, yeah.
patients in a much more
Yes.
appropriate manner.
Ankit, to
yeah.
tell you some positive point, artificial intelligence of very good help for all of us, especially
Yeah.
emergency physicians or critical care people, where the SOFA scoring and all the scorings are required for the people, right? So yes, hats off to artificial intelligence. It's a very good tool to us, provided we use it in a proper way
No,
at
I
our
completely
disposal.
agree.
Thank you.
Sir, I have one more question, which is asked by a lot of our viewers, especially in US, that we are doing a lot of research at the institution level, at the hospital level, at the ICMR and NHIs and things like that around the world.
Mhm.
But when the patient the patient first meets to a family physician or a clinic nearby.
Mhm.
Are we doing any research at the clinic level so that the clinic doctors will share their information to the institute?
To be honest, Ankit, if your question is to be taken, see, research is a time given apart from your clinical practice. A primary care physician in India, जो GP है, on an average is 200 patients in 4 hours. Okay, you tell me, Ankit, is it feasible for that physician or that person to gather data of such people unless he deploys somebody at the same time? You know, but in the West, where the countries you're talking, they are more institutionalized countries. They're more institution-based practice. They're hospitals for one syndrome itself, like interstitial pulmonary fibrosis. They are hospital ही बना दिया है. That is not in our case scenario. But what we have to tell is data is there. Data
Yeah,
is there, but good
yeah.
teachers are rare. Unless you have good teachers to help you to interpret data well and apply it clinically, and bring a smile and make something from worthless to worthwhile, it's of no point. All your research.
Dr. Sagu, what do you think? Sir, you need to unmute. Dr. Saggu, you need to unmute.
So when we talk about the research, I think there are three stages. There is a stage one, stage two, and stage three. Yes, if you talk about the family physicians, that is the stage one. So they are the collector of the data. They collect the data, right? And then comes the stage two. Stage two is the publication. Then that data that goes to a specific department. Then departments do they do the publications and all, right? And then stage three is an ICMR level, or you can the research peer research level. So they do the review of that publication and the data, and they do the research. So they are specific scientists who can do the research. Family physician and the surgeons, they cannot do the research. They can provide data in the publication, and that publication is being reviewed by the scientists at the research center, and they do the research. The same thing happens in the West also. The family physician, they are not the member, or they're not the member of the research team. They are the base level members. They are just to collect the data, and that data is being collected there and systemized. They being published over there, and that publication being reviewed by the researchers, and then the research they do the research. So this is a very systematic way the research is being done.
Right. I agree with
Do you think we need to create more innovation, or maybe
Yes.
maybe to improvise that research? But I'm not sure you have more knowledge that research can be done in a more appropriate manner.
Yeah. Because we have a problem. We Indians have lot of data, but we don't have a publications.
Yeah.
Our mind is not oriented for the publications. So now there are a lot of bodies has already been made for the obesity surgery, also for the cancer surgery, for gastro surgeries, for physicians, for pulmonologists, dermatologists. So every field has their own bodies. Now they what they are doing, they are stressing upon the publications. Now the lot of surgeons, the physicians, and the pulmonologists, they are working on the publications. So once this publication is being started over there, I think we can contribute to the research work of India.
Ankit, just to tell you, if publication researches are the guidelines and everything set apart, the COVID pandemic has proved to the world, okay, the kind of healthcare that exists in this country. Despite the best of the resources, we don't have, best of the minds, we don't have. Let us take it, we don't have, right? But still, the minds which we have are good enough to control something which is uncontrollable elsewhere, right? And the kind of synchrony which we have is fabulous, sir. So Ankit, coming to the point is an Indian physician thinks of lot many ways. वो जुगाड़ू होता है, वो हर चीज को उठा लेकर आ जाता है अपने पेशेंट के बेनिफिट, जो बाहर के फिजिशियंस नहीं करते कभी. अपने फिजिशियन के को देखने का नजरिया बदलो, बराबर. अपने हमें चाहिए पेशेंट को हमें देखने का नजरिया बदले, तो फिर वो देखेगा कि क्या है हम. इसके लिए आपकी मीडिया का बहुत हेल्प चाहिए हमको, क्योंकि वी हैव टू प्रोटेक्ट गुड थिंग्स ऑफ practice which are being followed. Many times, like my seniors, which I've learned with, have given the salaries for patients. Yeah, so good things have to be followed.
And I would like to invite Dr. Vineet Talwar,
Yes,
the
sir.
senior director at Rajiv Gandhi Cancer Hospital. Dr. Talwar.
Hanji,
can you
good
say
evening.
something about yourself?
Namaste. Good evening, Dr. Talwar.
Good evening, sir.
Yes, sir. How is it going in Rajiv Gandhi Hospital, and especially in Delhi?
Well, many times people confuse my hospital with the Rajiv Gandhi Super Specialty Hospital, which is in Timarpur. So
Okay.
ours is the Rajiv Gandhi Cancer Institute, which is in Rohini. So as far as
RGCI.
we are concerned, RGCI, we are a niche cancer center. And unlike the other general hospitals, we are taking care of only cancer patients. And of course, nowadays, we are doing active screening for the COVID patients also.
And sir, how is the situation?
See, situation is that we come across patients who turn out to be COVID positive. So depending upon the risk stratification, we send them to the COVID centers. And once they get better, then we continue the treatment. And as all of us know that patients who have cancer, they have high propensity to develop severe signs and symptoms of COVID. So that keeping in mind, we are very aggressive in screening these patients. So any patient who's for elective surgery, we are doing the COVID-19 testing. Any patient who's going for procedures like biopsies or endoscopies or bronchoscopies, where the uh, there can be a aerosol generation and can be harmful for the person who's doing the procedure. All these areas are the ones where we take extra precautions. Most of the patients nowadays, so-called patients, are coming asymptomatic. In fact, if you go by the statistics, about 60% of the patients are asymptomatic. So one has to be really wary whenever we are seeing the patients in the OPD or otherwise, whether they undergo chemotherapy or surgery.
And sir, also,
Yeah.
what cancer patient should know at this point of time during COVID? I mean, what are the things they need to know and to protect themselves because they must be coming for chemotherapies and for other treatments on day-to-day basis, maybe alternate days. So, what are the precautions or measures, or what are the information they need to know at this point of time?
See, there are no specific signs and symptoms which they have to look for, because they are going to be the same in a COVID patient or if it's a cancer patient with COVID.
Okay.
The other thing is that in cancer patients specifically, they have to maintain good hygiene. Point number one. Second, they have to have good hydration. You know, especially when the temperatures are now soaring, they should have adequate intake of water, preferably about 1.5 to 2 liters per day. And third, of course, is good nutrition, because you treat a cancer patient who has a poor nutrition vis-a-vis you treat a patient who's in good nutrition. Definitely the person who's with the good nutrition will fare much better. Apart from that, you have plethora of small studies in which some people have said that vitamin C is much better. People have said that addition of selenium and zinc in the diet is much better for cancer patients, or flavoprenols. And some people have said that vitamin D, if the intake is there, that keeps COVID at bay. But all those, if the randomized trials are not there, one should take them with a pinch of salt. Suffice to say, these three dictums one has to follow if one is a cancer patient. And definitely, whenever there is even a small fever, say 99 or 100, even a single spike, as compared to a normal individual who's immunocompetent, cancer patients, they should immediately report to their centers where they're getting treatment. And we should take stock whether it is, normal flu-like infection or any bacterial infection, or, it is a COVID infection which is brewing up in the patients.
So can I ask you a question, sir?
Yeah.
A general question to Vinith, sir.
Yes.
So basically, you deal with a lot of cancer patients. They are all immunocompromised because of chemotherapy or stuff like that, right? So what happens is, like, we depend upon nasal swabs for diagnosis as pulmonologists and HRCT chest picture, which shows a viral pneumonia sort of a picture, right? Because most of our patients are immunocompetent. But the similar picture can be even seen in immunocompromised hosts, which you guys deal with. So how is that you come to a diagnosis that could be COVID and this could not be COVID? So because the nasal swabs are only positive 66% of times. That is 34 people will be still be diagnosed as negative, right, or they being positive. So is there an algorithm which you have made or a scoring system which you have made by which you come to a diagnosis, or how do you do it, sir? The challenging thing, sir.
See, your question is very valid, because you have a patient who already has a compromised lung, and on top of that, you have a malignancy. So, how you go about it? And on top of that, what we say in Hindi, "Sone pe suhaga," you have COVID. So, how do you go about assessing these people? Well, first is, we take a detailed history,
Right, sir.
and we take a history in which if the patient has had any contacts with any patients who are COVID patients, or patient is in a hotspot, or the patient has had fever in the recent past, These things are there. If any one of them is there, then what we do is we do the pulse oximetry, because in the initial phase, all the COVID patients, they have a oxygen desaturation, which
Yes, absolutely.
in many times may be asymptomatic only. But then
Sure.
once the storm comes, then they rapidly deteriorate.
Right.
So we check the temperature, we see the physical condition of the patient, we do the oxygen saturation by pulse oximetry, we do the chest X-ray,
Yes.
and after that, when we get this basic data, we have a infectious diseases physician who's specifically dedicated for all the infectious diseases. We
Right.
bring that person into the loop, and if still we have doubt, as you said, that we bring in our pulmonary team. But then in almost 80% of times, with this kind of infrastructure and SOPs, we are able to, sift out, we're able to segregate which patients may be, possible COVID patients and which patients won't be. And then after that, even after that, we don't leave them alone. We have isolation wards. We immediately shift these patients from the triage to the isolation wards. We don't take them to the normal wards because they are
Right.
the clean areas. And in isolation wards, immediately we send the COVID test. After sending the COVID test, after say about 24 to 36 hours, if the test comes negative and the patient is clinically improving and the patient does not have any desaturation or symptoms of fever or respiratory deterioration, we shift them out of the isolation wards. But if we still have any doubt, we keep them there, and after say about 4 or 5 days, again we repeat the test just to be doubly sure, even if
Right.
they are negative. 2 times negative, then of course there's a limit to which you can keep on testing for COVID. Then that is the time we shift the patient out and we treat them like regular cancer patients.
So there has been a study which shows that the salivary samples are
Are
more
better,
specific,
are
better,
better. Yes,
better.
yes,
Do
yes.
you
Yeah.
want to implement that in your cancer patient? Because in cancer patient to get a sample is itself a difficult job, right? To get a
Well,
pure sample.
see, there are lot of problems, lot of practical problems when you go about taking samples. You have to make sure that your technical staff or the technicians who take these samples, they are also well versed with taking saliva samples. How
Right.
much to take, when to take, whether the patient should be fasting or not. Most of the technicians who take these samples, they are quite well versed with the throat swab. So, so that comes as a practical challenge. But yes, studies are now showing that saliva is definitely better.
Right.
And of course, it is easier also. But then there is a learning curve. You have to teach your staff that,
Right.
at this point of time becomes a challenge when you are, doing firefighting.
Right. So, can I ask you another question? Being an oncological unit, there was a study from China, Wuhan, which showed the concentration of viruses in the hospital area. Right? They found the maximum concentration of virus on the mouse of the ICU, led to a lesser degree on the floor of the ICU, but the pharmacy had the 100% swabs coming positive. Is there a way where you can deploy UVC lamps? Because so you deal closely with radiation technology, so I'm asking you, is there a way where you can deploy UVC lamps, far light lamp at 222 nanometers, to achieve environmental sterilization? Because what I feel in my personal experience is hospitals are becoming secondary niders for community outbreaks
Yeah.
of COVID.
No, that is again a very interesting question. What we are doing is, you have to think everything in totality. You can't just go by the book. So, do in Rome as Romans do in India as Indians do. So, what we are doing is we are spraying hypochlorite. You have to identify areas which are at a maximum risk, and studies have shown that the walking tunnels,
Yes,
the
yes,
areas, the walkways which are narrow, they are the ones which harbor the maximum virus. So the pathways which are narrower than say about 8 feet, and
Yeah.
people are going through that, we are spraying that with hypochlorite solution every 2 hourly, every 2 hourly. irrespective.
Oh.
So we have identified those walkways where the patient movement is maximum, and it has been seen, the patient movement is maximum in OPD areas, and wherever you have alleys and corridors which are narrow, they are given maximum, thought. And of course, the areas where OPDs are there, testing areas are there, labs are there. There also we keep on spraying hypochlorite, and there are dedicated ward boys which keep on scrubbing the most common handrails, grab rails after every 4 to 5 hours. Even in our OPDs, I make sure that there is a chap with a mop who keeps on mopping almost,
Yeah.
because by the time he finishes from one end of the OPD to the other side, it is almost 1 or 2 hours.
Oh.
And then again, we have told him that after every 4 hours, you have to mop again. So the another chap starts from the other side. So, do in India as Indians do. That is what we are trying to do. Because UV, of course, that is a good thought, but then practical feasibility is a big problem. So spraying, hypochlorite is not that costly. It's about 700-800 to a liter, and you have to make it in a dilution. So that is the cheapest way to go about it.
Yeah. Here I would like to add on that
Yes.
what we are doing, we are mopping the table, sofa, and the patient bed after each and every patient in OPD. After each and every patient, we are just there is a one guy who is doing the same. This is only he's only for the mopping, and he's spraying the hypochlorite and mopping with the hypochlorite. The patient bed, patient sofa, and the doctor's table.
Right.
So we are doing that, but apart from that, we are mopping the floors also. And
Yes,
Because
the
that is 2 hourly. Floors are 2 hourly.
and the examination couch which is there, we are not using the standard sheets. In our daycare wards, we are using those, disposable
Paper sheet.
paper sheets.
Yeah.
And
Even we are also using a paper sheet.
They come very economical. You get it in bulk, you get a good quotation.
yes.
So, you have to improvise whichever way. You can't go by what the Western literature says.
Right.
India is 1.3 billion, and even if you talk of metros, you're talking of 10% of the whole. So 10% of 1.3 billion is equivalent to 6-7 European countries.
Yeah.
Right.
So you can't extrapolate that to the Indian scenario.
So agreed totally to you, sir, on the methods of it. But a UVC lamp, this what like a thought came to my mind. If you deploy them in areas of high concentration, far light UVC lamps, it is you get rid of the person who is going to mop your floor, because the person who is going to mop your floor is going to become more infected one point or the other time of them. You cannot have you 100% protection rate every time. So to save that person's life, a lamp, okay, you just have to install a bulb and just leave it at that. It is. So because I thought of this idea, because if we don't think tangentially and we don't think out of the box, out of tradition, the rate at which COVID is growing right now in our country is on a log phase, sir. It's an upright curve still. We have yet to reach the peak, and rainy season is approaching, sir. So how effective will our methods be of mopping and everything in the rains? Because they all will go for a toss, sir, in a larger
I
scale.
think
So
I
that's the
think
thing.
we have to change our thinking,
Right.
thought process. And first thing which should come into the mind is that every patient which is coming to you in the OPD is a suspect COVID patient,
COVID patient, right, sir?
until another, taken otherwise.
Yes.
Because most of these patients are asymptomatic. So if you
Right.
have that thought process in mind, automatically
Yes,
your
sir.
SOPs will go accordingly.
Yes, sir.
Then, of course, as a policy decision, you can say whether you want to use hypochlorite, you want to use ultraviolet, whether you want to use disinfectants, or you want to use any other kind of, antiviral or germicide dull drug. That is up to you. But
Yes.
till the time you don't change your mindset, nothing is going to happen.
Right.
And I think that we need to follow this mindset for a long period of time, because COVID will
Right.
stay here. And if we have a vaccine, maybe in next 6 months, 6 to 8 months, still we have to follow these precautions, which is self distancing, physical distancing, and following the washing hands and using sanitizers, and maybe wearing a mask. Mask could be unnecessary. So I think we have to follow all these things. But as all doctors are on panel right now, you are the front runners, and so all our viewers would like to know that they are wearing N95 masks and they are wearing different masks. So how important is to change your mask and how important is to protect your mask so that you can use it, maybe 4 5 times, not more than that. Because people are tend to use the same mask again and again. They are not following the pattern of changing the mask.
Uh, Ankit, if to answer your question of N95 mask, each mask has a shelf life recommended by the manufacturer. N95 mask without a valve has a shelf life of 4 to 6 hours, and with a valve, the shelf life increases to 12 hours. Now, it is very difficult to spend 4 or 500 rupees every day to
Yeah.
get a new mask, right? Which is difficult for us. I will tell you what my friends in the US do. That they have a lot of bulk patients coming in. They wear an N95 mask. About that, they wear a surgical mask, and about that, they wear a paper mask.
Okay.
Okay, what is changed is the paper mask, and there are 5 masks kept in a row, and each mask 1 day is sent for UV sterilization, and one mask is used after every 5 days. This is the way they have rotated the masks successfully well, and since the time of pandemic which has happened in US, till date none of them have got infected with COVID, which tells me that their mask rotation policy somewhat we have to adapt to ourselves. We have to rotate our masks. We don't have to keep wearing the same mask again and again. But after a particular period of time, we can reuse the mask. After it's left to some treatment or UV light ethylene oxide treatment, or just left to dry in the sun. Because the virus dies at different rates on different surfaces, which I spoke to you in the first interview.
I think I would agree with Dr. Rahul as he's saying. We are also following the same policy. 5 masks, and I personally, what I do is the time I take it out, I leave it out in the sun,
Right.
auto sanitation.
Yeah.
Yes.
And then, depending upon the days I keep on using it, I use it 4 times, and fifth time I discard it.
Right.
After 4 or 5 times, it is not advisable to use it. So if you have 5 masks, generally about say 3 weeks you can use it. And again, it depends that you don't necessarily have to wear a N95 mask everywhere. If you are in a COVID hospital, yes, 100%. If you are in
Right.
a non-COVID hospital, and if you are in a low risk area, I mean, if you are in the OPD or you are just in the lab, then a 3-ply surgical mask can suffice, but that is disposable. You cannot use it again. You have to throw it off. And the moment you find that your mask is getting wet with the humidity or something,
Yes.
or there are some dirt or something, then immediately you have to discard it. You cannot use it in N95 or the otherwise. And if you're in a high risk area, say OPDs where the patient interaction is there, then you make sure the distance is about 1.5 to 2 meters. Initially, we used to
Yes.
say 1 meter, but now
Yeah.
it is about 2 meters.
2 meters.
Although there are studies, which show that the aerosol can travel about 20
4.
to 24 feet.
Oh.
You know, there are studies, but then the general idea is 2 meters. So 2 meters distancing, you can wear a 3-ply mask, you can discard it, or you wear a N95. You have the 5 masks, as Dr. Rahul said, and then you keep on rotating it. And of course, the interaction time should not be more than 4 to 5 minutes.
Yes.
And if possible, don't examine. If you think there is a great need, then you have a partial PPE, a disposable gown, and you have a N95 mask and a visor. Examine the patient, and you have to, there should be a duffing and doffing. You have to throw that, all the mask and the PPE, and again change the cap and the mask to see the next patient. And
Yes.
between each and every patient, it is always better if you have soap and water.
Yes.
It is always preferable to the hand rub,
Right.
because hand rub has its own
Adverse
utility
effect.
time.
Yes.
Yes.
And to add to what Sir said, it is very good to what Sir said to use a soap and water, because soap and
Yeah.
water is the most effective thing. Time limit is 30 seconds. Again, I stress on it because there's a data which shows using soap and water for 30 seconds. Proper handle it minimizes the risk of transmission, right? That's a very good thing which we can practice and we can follow there.
No, sir. Very
And
well
one
said.
add, yeah, when you have a bunch of masks, I
Yeah.
found it out myself. Please cut one mask from a random bunch and see what is there inside it. I found a tissue paper instead of N95 layer in one of the masks.
Oh my God.
So,
And that
so
was
that
a Indian mask or a imported mask?
A tissue.
sir, now to be honest to you, imported masks we don't have much access to. They're very expensive. We always use the local made masks available to us, whatever the institute gives us. But we do have a policy that the mask will pick it up at random, cut it, open it, and check it for us what is there inside it.
So good afternoon, everyone.
Good
My
afternoon.
apologies for being so late. I just got back from my first doctor's appointment in 2 months. They figured out I needed my treatments, and so they worked me in. It was quite a journey, an experience too, because I just want to share it with you on how things have changed. But from the moment I arrive in my car, my vehicle, I stay parked outside. They come out to me and they interview me. They're all masked, PPE and everything. And then I follow them in and I wash my hands at the door, or that one layer of the door. They have 2 layers.
Yeah.
And so I do my hands and get a mask. And like Dr. Saggu taught us how to wear it, they want me to wear blue out. So I put it on and wash my hands again. And then we go to another door. And then I do my my regular check-in where they weigh me and they put my bands on and stuff like that. But it's very hard because it's hard to speak through this, right? And you could tell they're having a hard time communicating with us, but they do this very well because they're experienced. So, but every time we touch something, they tell us to wash, to gel our hands. But every time we touch something, if we touch a door, wash your hands. If we go into a room and they put the meters on our oxygen meters on our fingers and everything, because they do our vitals, wash your hands. It was interesting to do my temperature because they still do it under the tongue with a mask. So I was expecting a scanner, but they still use the regular thermometer. But after all of that, my treatments went normal. So we did everything went normal, except when I was done, they could not do any prescriptions. This was just flow in and out. And I exited out of a door I never even knew existed. And I've been in and out of that building for years. And I thought I knew every door until today. And I couldn't believe it. And they go, oh, no, we can't have risk of any patients bumping into each other at all. So I found out that there's another back door. And it exits out to actually my favorite place, which is they have a big, beautiful water pond and picnic area back there. So, but I've never gone that way before. So anyway, that was my experience, a new experience with the doctors. They asked me how I learned to wash my hands properly. They go, Kim, you've become an expert. And I go, watch my show. Watch our show. We have Dr. Saggu and everyone. So they taught us how to, Dr. Saggu taught us how to do that and wear the mask. So, so I was considered an expert today, and I was happy. So, and I'm happy because I got my treatments. I feel better. So,
So Kim, we were discussing the same thing with Dr. Vipin and Dr. Pulmonologist Dr. Rahul from Mumbai and from Delhi. So the same thing we were discussing, how our OPD has changed now, what the policies and SOPs we have changed regarding our OPDs, IPDs and OTs also. So I think the same screening program is also running in our hospitals, in our clinics also here. The same thing, we are receiving the patients from outside and we are screening the patients there. And inside the OPD also, we are doing disinfecting all the surfaces after each and every patient. Yeah, we are asking the patient to wash the hands, and even we are also washing our hands after each and every patient. So the same,
No, it's it's interesting because I didn't know what to expect. I have not been to any of my physicians at all since, and actually the doctors inside the building, they don't know what's going on out there. I have a very good rapport with my doctor and physician. She's been treating me for many, many years, and my disease is so rare. She's really always taken particular interest in. And then so she asked me, "What is it like out there?" And I told her, and she goes, "I had no idea they're meeting you at the car." She goes, "Oh my gosh!" So interesting enough, because, and I don't know if it's like this in your country, but we have a really bad problem with drug dealers and drug people. And this is considered a pain clinic, even though I get treated for other things, neurological problems. They have a armed guard in the lobby at all times because they have drug dealers come in with guns and try to steal the medication from the clinics. So, and he's still there, but he's got a mask on now. So,
So that is why now this is the global village. We are speaking the same language. Each and every person from every part of the globe. We are speaking the same thing. We are following the same policy. We are doing the same thing. I think this is the first time in all of the world. This corona has, brought us in the global village.
The global village, we're one now. And this is something, I think I was texting a question while I was driving and listening. I wasn't driving and texting. I stopped at a red light. But my journey is an hour. So that's why it took me so long. But anyway, I wanted to know, what can we do globally to connect? Because it seems like, everybody's doing these common practices. I'm sure the WHO is sharing information. I don't feel like they shared it very well, or CDC shared it very well in the beginning, but maybe somehow we can connect data and information globally so that we can continue to operate without ever having to close down again when this happens, because this will happen again. This another virus will attack us again. Is that your thoughts, Dr. Saggu?
Yeah, at least we should be ready to fight against any type of the outbreak. At least we should strengthen our healthcare. What was lacking behind us, as we were not investing on the healthcare. So at least now we will start to invest in the healthcare globally. I'm talking about the globally also, in India also, because our focus is not on the healthcare. Our focus is on other things. So I think we would be investing in healthcare, and definitely we would have a power to fight against the type of the outbreaks.
No, I agree with you. Some of the interesting things is that I learned today too is that we had 30 more new deaths reported in just our state, not the whole country. I'll have to pull up the country, but given that, and I think that's a high number for a small state, and they've not really disclosed to us how many people have been tested positive, but they've decided to continue reopening. And so they will be reopening this evening at 5:00. So where we closed down 5:00 on Friday, maybe a month ago, close to 45 days ago, they are reopening this evening, which I think is kind of stupid because all the bars are going to be open. Everybody's going to be drunk and crazy. And, I think our infectious rate is going to go up like this. And maybe they're doing that on purpose to teach us a lesson. I don't know. But they're opening Friday night. Like, what is your opinion of that? What is your opinion? You laughed. What's your opinion? It's funny, yeah.
Kim, we have reached up to that stage of the COVID-19 now. We cannot have a check on the infections. We cannot check the infectivity rate. I mean, a lot of people, they are going to become positive now. Becoming positive for the COVID-19 is not a dangerous, but having a severe complications because of the COVID-19 is a worry. So what we can do, we can control only the death rates. If we can control the death rates, at least we are bringing down that fatality rate. So that is the only thing we can control. infection will go on in the next few months. You will see a lot of people, they're going to be infected.
No, I think we're going to see that. So many people are pushing to reopen. They said that the economic situation that we're dealing with doesn't compare. That they feel like the deaths are worth the economic situation because they keep saying it's such a low death rate, and I go, that's so rude. That's just that's not humane. I don't know how you doctors feel about it, but I just don't think it's humane. I know that you are to expect deaths with every flu we have, every kind of disease we have out there. There's an expected ratio of death, but to know that we can prevent this in some scalable model for a while, just for a while, we should take those precautions. But they're not even exercising precautions. There are no rules in our reentry. I have not heard one rule of wear a mask. Not heard one. And wash hands. Wash hands. I do that. I have my gel. I am like OCD, right? So I'm gonna have this with me everywhere I go. This sprays. I'll get some sprays. But right now, I'm not going anywhere other than this was my first trip out, and I went to the doctor's, and I went to the store last night because we had to go to the store. But I literally, it's been almost a month, and not even the store. I didn't even go to the store because I knew that the virus was going to be really climbing higher, faster. Yeah. But I was shocked at the people not wearing masks. Mm-hmm. Even when I got to the doctor's office, I had a mask on, and they laughed at me, and then they gave me their mask. They wanted me to wear their mask. But I would drive by and see people coming in and out of stores, no masks, no. It was shocking. I don't think people are going to have good practices, at least not in America. What's it like in your country? Is your country got the practices down?
Yeah, they are following the practices, good practices. Everybody is wearing masks. That is good. But the problem is that we have some categories like laborers are there, and they are having very difficulties regarding their shelter, regarding their food. So that is why they are migrating from one place to another place en masse. And that time they are not following the principles of the social distancing also. And for our surprise, 2 days before, our government has opened up the liquor shops also. And because the liquor shops, there are long and long queues are there, and those people, they are becoming very crazy, and they are not following the distancing anything. Just they want to have a lot of liquors. They want to have 15 to 20 liters one person. So that has made our country vulnerable to have more infections. And it's right also, it's true also. In last 2-3 days, we have a lot of people positive. 4,000 in one day, we got the positive patients. So if we would not be, so, it is very, now what we need to have a good economy. We need to lift up the lockdown so that we can survive now. Earlier, we were saving the lives. Now we have to save the livelihood. To save the livelihood, we need to partial lift up the lockdown. And that is only possible when you will follow the guidelines, when you follow the preventive measures. That is very important, because our government can give you relaxation, but the virus is not going to give you relaxation. So that is why you need to follow all the social distancing guidelines. You have to follow the hand hygiene. You have to follow all the etiquettes, sneeze etiquettes and cough etiquettes. That is very important. So once we would be following all these measures, I don't think there is any problem fighting with the COVID-19.
Here's the situation that people need to consider. I don't know that it's fighting because, and I've been listening to all of your reports and everyone else's. I think statistically, the mortality rate is probably the same as with anything else. It's the infectious rate that the hospitals and medical industry could not maintain. Right? Look at there. But they cannot maintain.
It's a tissue paper inside the mask.
Yeah, it's just tissue paper. That's what I tell people. It's not hard. I don't think any of them are real standards. I really don't.
This mask is also
This is
having
what I drove up. This is what I drove up with. This is my mask.
Right?
So here,
Better. They told me
this is material. You remember when we go for the suit?
Here, Kim, I would like to. Kim, I would like to comment upon all these masks, because the mask which you are having, that is a wall mask. So the wall mask, they are of no use, because once you exhale into the mask, you will see there is a big space that can have access to a lot of viruses.
Oh.
So what we say, the respirator mask or the wall mask, I don't think they are the good quality mask. The simple triple ply, 3-ply surgical mask is good. Or what you can do, you can have any cloth cover. I'm talking about the general public. If you don't have any COVID patient in your vicinity, you can have a simple cloth cover. That is very important. Or what you can have, if you see this,
like a scarf.
Yeah. So scarf is good, but if you can see this is a handkerchief. You can fold this handkerchief into 4 layers. And now what you have to do is just you have to fold from here, right? And fold from here. And now you can put 2 rubber bands on both the sides. And this way you can have a very good mask. You need not to spend any, you don't need to invest into your mask, and your mask is ready.
Or you can just wrap your scarf around a couple of times, and because I have a 2-ply in here, and
here you see your mask is ready.
Ankit, coming back to the question of masks, you found a tissue paper, right?
Yeah, that's what
Was it worth spending so much? My question to you is, was it worth? Right. Now coming to the basic mask hygiene, Ankit. It is good to use substitutes if you are not dealing with COVID patients directly. Okay. If you are not dealing with COVID patients directly, you can use whatever substitutes you want. But if you enter that fortunate area called isolation zone, mind you, nothing less of NOIS
N95
or N99. Okay. There, don't do the experiments, please, of wearing your handkerchief and things and take our names there. Doctors on the show showed us handkerchiefs and stuff. This is for your routine practice at the home.
This is for the general public. This is for the general public.
Traveling, right?
Yeah.
Let us. I'm making it very specific to general public when you're traveling, when you're out in the environment, right?
Yes.
When you enter an isolation zone, the norms have to be strictly followed. That is what it is.
No, and I think it's just going to be disciplines, and that we're going to have to enforce. I think we're going to see a large spike when we do re-entry, because people won't know how to behave. So I'm going to stay home while they re-enter. I got a lot of work to do anyway. I've got a book I need to start back up and finish. I got a lot of work to do. So,
sure.
I think we need to just be respectful and do this patiently. And I just, I was listening to about the schools, right? And somebody had told me that, how we have the next generation of kids, and they're calling these the lost generation. They feel like that the children are going to lose so much by not being educated properly. And there has been talk about not letting the schools re-enter this August. I know our university has already voted on it. The one I sit on the board at, they already voted on no re-entry this year. Several other schools are saying we'll see how it goes through the summer. But we also know that this is a disease that spreads in the cold, so it could, reinfect us in the winter. I think if they let the children go back to school, we just got to think smart about this. They say children get through it better. I've heard different stories from different doctors about the youth getting it. They said that oddly, people from the age of 25, I think it is, to 35 are having strokes from this. And I don't know why, but they have been reporting a higher stroke incidence in that age group with the COVID. So I think that's interesting study that somebody should do. And not us, but I hope that somebody studies that, because that tells me that the disease gets into the bloodstream and does damage. So there's a lot that we just need